So let's move into the meat. The risk mitigation strategies. Let's really spend some time talking about this. And the first strategy is really the safe environment, and designing one that does minimize ligature risks, anchor points, and what we know. James Hunt and David Stein, of course, are the authors of the design of the built environment, which I have in your reference for you, that the Joint Commission and CMS are using as their guideline for safety in the environment. And they have anecdotally made statements that they believe that we can eliminate 80% of the risk with behavioral health patients by designing a safe environment. So that if we design that environment, we only have to worry about 20% of the risk. So the space, and I understand EDs not wanting to give up a room that is just designated for one particular population, but the room can be convertible. There are garage doors that can go on the back to cover all the equipment. There are other safety modifications that can be made, so it can be easily converted back into use for a primary medical patient. But having nurses empty out a room in the ED and spend time doing that, I don't think is a good use of resource and personnel. So I think from a leadership perspective, we really need to look at how are we making care of the patient easy and the design of the environment effective so that we can keep patients safe and don't overutilize resources that we have. The room can be designed as a seclusion room. It can be both a safe room and a seclusion room. It should be away from all exits and an ambulance bay. I can't tell you how many risk assessments I go on and go into the ED, and they've designed 4 beautiful rooms, and they're right by the ambulance bay, and the door's opening and closing and opening and closing. And I ask, have you ever had any elopements? And they go, oh, sure. And I chuckle to myself, but then we have to have a discussion about, they've mitigated one risk, but now they've created another risk. It should be close to the nurse's station so that there's good visibility, and we need to provide diversions for patients that have long length of stay, have anxiety, and that means having a television in a room. I recommend having an activity cart, something that has cards on it, adult coloring books, anything that can work to keep patients occupied and less anxious will work. So these are strategies for all behavioral health patients, and we're talking about the ED primarily right now. They should all be searched, and that means, and this is a standard of care, by the way. I have had organizations tell me, we don't search patients because it's a patient rights issue. Well, first of all, it is not a patient rights issue, and second of all, safety trumps rights. So when we are talking about a high-risk patient, our duty is to then make sure they're safe, and the only way we can make sure they're safe is to really do a search. So a thorough search should be done. I am a proponent of use of an electronic wand at the point of triage. So when we have a patient that's identified at risk, I think that it behooves us to have security wand them very quickly and their belongings to make sure that there is no hard metal that's going to be coming back into the ED. I think it helps staff feel safer, and it helps protect the patient. Some EDs are using different colored gowns, or they put different colored socks on the patient so that they can detect them quickly if they're getting up and moving around, which I think is a good idea. Personal panic alarms for if there's a dedicated behavioral health area. The staff that are working in that area really should have a panic system. The recommendation is to secure the ED for entrance and egress, which can help prevent elopement. A lot of life safety codes allow for that. Minimally putting on a 15-second delay can help mitigate elopements out of the ED and also control flow. Routine surveillance of the rooms and the patient is very important. So it's not enough to just design the safe environment, but we have to keep checking it to make sure it's safe, particularly if we have visitors and other people coming in. And let me just speak a second to med-surg. more and more new buildings, new healthcare organizations are building in safe environments on medicine units and building in maybe one room that is designed safely so that if they have a patient that has a dual diagnosis or a primary diagnosis, that they're more comfortable, that they can be safe in that space. So that's something that I recommend, even for established organizations. It's not that financially stressful to do that, and could really help not only mitigate the risk of harm, but also help decrease the need for sitters, which we're going to talk more about. One of the means by which we can let the community know that we have this culture of zero tolerance and that we don't expect anybody to be disruptive is that we post a notice. And these notices can be posted outside the ED, outside the hospital, main hospital, where it, first of all, says no weapons. And that's pretty common right now for organizations, but I have been to some where they don't even have no weapon signs. And then another notice that welcomes the person or the visitor or the patient and simply says something to the effect, we expect that all patients, visitors, and staff are respectful and non-disruptive while in our facility so that we can maintain the safety of everyone. This puts people on notice, and I make it akin to security at an airport. I fly a lot, and I know when I walk in an airport that I can't act out. And I think that is the message that we want to give everyone that walks into our buildings. And I know that if I act out in an airport, I know what's going to happen. And that's also what the community needs to know. If you are disruptive, we are right on it, and we will not tolerate it. It will end right there at the lowest level. And we're not there yet in healthcare. We let things go on and on and on because the patient's sick or because we have big hearts. We're very compassionate and we're nice and we're all those things. But when it comes down to safety, we can't expect that our patients, our visitors, and our staff are safe if we allow disruption in our treatment environment. So the chemical dependency risk, let's talk about briefly. And, I say on and on and on to organizations that are really challenged with this population is, when these patients present, they really are in pain. And the fact that we may want to deny that or ignore that only creates risk. So we need to have standard withdrawal protocols for alcohol, particularly, and benzos, and opiates. Because if we do, then we can manage the patient safely and they'll be comfortable, which will then minimize their risk. So, if your organization has experiences with delirium tremens, DTs, that is a medical emergency. That is an adverse event that happens in a hospital. A DT should never happen in a hospital. The patient can come in with DTs, but they should not go into DTs, which means we have not effectively managed their withdrawal. There should be opiate prescribing protocols for the ED. Most states now have a pharmacy monitoring system, and this will soon become the standard of care, that any physician prescribing an opiate will have to check. It's not going to be an option. Have to check to see where that patient's getting prescriptions for opiates. But if an ED does not have consistent protocols that all physicians are following, then they are then putting themselves at risk. We need to manage anxiety with these patients. If they are in our ED and if they are anxious, we need to attend to that right away. We need to not let them stew and get more and more anxious and ignore them, because if we do, they will up the ante and we will continue to have an unsafe situation. And we need to set limits. And, more and more when I do risk assessments, I'm hearing from staff, we want to set limits, but We have this thing called patient experience and the patient, satisfaction survey. And so they feel as if they set limits, then there's going to be a bad experience by the patient, and the ratings will go down, and then they'll be called on the carpet. And I really would like to caution leadership on this, because I think that, first of all, I don't believe that this should be a outcome measure, but that's my personal opinion. But second of all, I think if we give staff the idea that you cannot safely manage patients because you're worried about a score going down, then we have consequently really made the environment unsafe. So that is a leadership issue that needs to be discussed. So let's talk about observation and monitoring, and we can talk about sitters. I'm going to go through this fairly quickly because we don't have a whole lot of time left, and I want to leave time for questions. But we can have sitters. We can have routine checks. These are the standard routine checks for behavioral patients, Q15 minutes, or we can do routine rounding. And I want to talk a little more about sitters, which are typically high cost, high resource. Organizations spend a lot of money on sitters, and right now they're typically untrained. They are often not part of the team. They're unfamiliar with policies, and they are blamed when things go wrong. But worse yet, there is no evidence to support that sitters decrease risk with behavioral health patients. And, I think that we have to remember that. Not only do we have sitters that don't have the competencies to safely manage a patient, and I make it akin to putting a staff person who's untrained to watch a telemetry monitor that doesn't even know what they're looking for, doesn't know how to respond or react. So we need to understand that if we are using one-to-one sitters or patient safety companions, and I'm from the old school, so I call them sitters, that we need to assure that they have demonstrated competencies. And I actually have given you, I think, some sitter guidelines as part of the toolbox, and also have a sitter training module. So you can always email me, and I'll be happy to share any resources I have with you. Safety contracts. I don't see them too much these days, but there's still organizations that are relying on them. And when events happen, they'll say, oh, the patient signed a contract. Well, first of all, that's just silly. Second of all, they're not the standard of practice. They give us a false sense of security. There's no evidence that they prevent suicide, and they're not legally binding. So if you are using them, you need to just stop that process, because we do want to ask patients, though, about their safety and how safe do they feel, either with themselves or towards other people, and we need to document that. Restraint and seclusion is still a very, very hot issue, and it leads to lots of liabilities and CMS immediate jeopardy findings. But it is the consensus that there's safety interventions of last resort. Staff do need to know and follow the federal regulatory guidelines. More and more, I go into EDs, I go into acute care. Staff are holding down patients, giving them IM medications, and not considering that a restraint. There are also lots of questions and confusion about what a chemical restraint is versus a physical restraint. So they need to know the definitions of restraint as laid out by the Joint Commission, by CMS. And, of course, Joint Commission has adopted them. Documentation is essential when we talk about this, because that is the record of this high-risk intervention. And if the documentation is not complete and there is an event, the organization is going to be held liable. Joint Commission has recommended that organizations have a restraint reduction committee where they look to decrease the rate of restraint throughout the organization. So if you have not implemented that, that can be a highly effective committee that looks at causes, reasons, procedures, updating systems and processes for the use of restraint, as well as monitoring of the data. All right, competencies, of course, can be a whole conversation seminar in and of itself. But, the highlights of this are that not only do nursing staff and physician staff need to be trained, but everyone in the organization, the acute care organization, needs to know and be competent about behavioral patients and what precautions they need to take. For instance, dietary, not sending up metal forks and knives. Housekeeping, not leaving chemicals sitting around in patients' rooms, or there brooms left in rooms where patients can take them and harm somebody. Sitters, of course, we talked about. Maintenance, when they come in and do repairs, to make sure that the patient is safe and that they don't leave tools behind. And then, of course, security. So if we have security, which most organizations do, they have to be competent in nonviolent management of patients, as well as possibly other law enforcement tactics. So this is a list, basically, of what I think are the main competencies that staff, that actually I think all staff should have, but minimally staff that are managing behavioral patients. Respectful approaches. And if I had a dime for every time a patient got upset because the staff wasn't respectful, I would be sitting on a beach in Cancun or the Caribbean. Competencies in assessment and reassessment of patients, which isn't always easy with staff that really are primarily medical or surgical staff, but a necessary competency. Of course, de-escalation, crisis intervention needs to be more intense with those that are primarily working with behavioral patients, but everybody should be given some competency with how to do de-escalation, because they're managing visitors, they're managing patients, they're managing other staff that escalate. So everybody needs to understand that escalation cycle and how to decrease the anxiety. Of course, restraint and seclusion I spoke to in terms of the federal guidelines. Involuntary commitment procedures. If the ED is committing patients or detaining patients, they need to be very well versed in those procedures. Withdrawal symptoms and management. Nursing staff on the medical units need to know the pathology of substance abuse and withdrawal and what they need to be looking for and what they need to be assessing the patient for. And then critical junctures in care. And when I talk about that, there are many critical junctures with this population that increase risk. Things like transferring them from one setting to another, from one room to another, from one department to another. Telephone calls can be critical junctures. Visitors can be critical junctures. And when those times happen, we need to take extra care to assess the patient after those events. A workplace violence program I spoke to, and again, that's a whole webinar in and of itself. And then documentation and how to adequately document the assessment of the patient's symptoms for which they're being treated. So lots of times in the ED or in medicine, the nurses are charting the medical piece, the vital signs, the urine output, et cetera, but they're not noting what's the behavior of the patient or what's the anxiety level of the patient and what have been their interventions to safely manage that. And then behavioral health resources. And this is where we lag behind. We have, as I said earlier, really dismantled the behavioral health system, and in doing so, we've also eliminated a lot of positions in organizations that used to be resources for the staff, for the patient. And here's some things that I think that we need to consider. Peer counselors. There's a lot of literature on that for use of peer counselors in emergency departments to work with patients that present with chemical dependency, that they can introduce themselves and they can begin to assist the person potentially into detox or into recovery. We know that EDs are managing a highly chemically dependent population, so that if we have immediate contact with the correct resource, we may be able to work to not only decrease readmissions, but to move that person into recovery. We need a behavioral health trained evaluator. So if that's a LICSW, if that's a nurse therapist, if that's an NP, if that's a physician or psychiatrist, that's fine. But if you are having ED staff evaluate or do the full assessment of patients that are behavioral health, then that really is not the standard of care right now. We really do minimally have to have that resource. And a lot of organizations have moved to telepsychiatry for this, which is actually quite cost-effective. And when I go to organizations that are using it, they really do not have any significant concerns about it. It seems to work fairly well. It's timely. It gets the assessment done very quickly and can help move along the disposition of the patient. So there's many organizations out there now that are doing telepsychiatry that you may want to look into as an option if you don't have on-site evaluators. Code Gray teams, and Code Gray, Code Green, Code Armstrong, those crisis teams really do need to be in place that are called throughout the house. And then in addition to that, many organizations are moving into building a behavioral health rapid response team, just like a medical response team where the medicine nurses can, if they have a patient that's getting agitated or confused or delusional and they've ran out of tricks in their bag and they're fearful, they can call somebody or a team that can come to help be proactive and manage this patient before it gets to the extreme on that escalation scale. And this is proven to be very, very effective. And then last, quality and risk management. The organization needs to have a culture of reporting. I typically see a lot of underreporting in organizations related to behavioral health events, aggression, violence, suicide gestures, elopements, so that the risk folks and the quality folks really need to help staff understand that through that reporting, and I believe in database change, so that through that reporting we will have data to create positive change for them. We need to collect the data, we need to analyze it, and we need to trend it, and we need to put it out there for staff to see. Staff love to see data if it's presented in a way that they can comprehend. Debriefing and learning from defects are absolutely tools for risk management. They're used in high reliability organizations, and my recommendation is always that any time there is a behavioral health event, that there be a debriefing of the staff that are involved in that event. I have debriefing tools that are brief, 2 to 3 minutes, 5 minutes max, where staff can go through a process and learn. Crisis is the time for learning, and this on-the-spot, just-in-time training really does help them build skill and learn from events that occur so they can be more proactive next time. Of course, we should be doing root cause analyses on sentinel events, but recommendation is that we do them on, we do a proactive RCA, maybe on a comorbid behavioral patient that had a less serious event, that we do one annually to see how we're safely managing the patients. And then, of course, conducting a risk assessment. Having somebody in-house do a risk assessment to see where you are now and how are you safely managing the patients. And I can tell you, organizations that do a tracer of a behavioral patient really find out things that keep them up at night. So conduct a tracer of a patient or conduct a full risk assessment in various areas of the environment, of the leadership, of the culture, of your policies and your procedures, and really look at how are you managing patients now and figure out your gaps so that you can then move forward in providing safe and less risk care.